You're listening to This Week in Cardiology from theheart.org on Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or, Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for November 20th, 2020. This week, COVID vaccines, and some AHA reviews. First, an announcement. It's Thanksgiving holiday next week, so I will see you in 2 weeks. Now, as far as COVID goes, U.S. listeners know the story. The situation most places here is bad. Even our place in Louisville, which for the entire pandemic has stayed steady at about 5% of beds being for COVID admissions, is now seeing a near tripling of cases. It's unnerving, really. I must admit to being perplexed at where all these cases are coming from. I say this because people wear masks here. While restaurants are open, they've been open essentially all summer and fall. Why are so many cases now as opposed to a month or two ago? I see from the graphs that much of Europe is now coming down from the peak, and I suspect that we will too soon. People self-adjust because people generally are good. Now to the vaccine. This week brought more good news in the form of the Moderna vaccine, which was also announced with a press release. It was very similar to the Pfizer results. 95 infections in a trial of about 30,000 people. 90 of the 95 infections were in the placebo group. There were no significant adverse effects, and the vaccine does not have to be stored at super cold temperatures. Also this week, Pfizer announced it had hit its safety milestone and will be applying for an emergency use authorization. The 90% efficacy was upheld. And for the win, there are still more trials of more vaccines to come, and this is good news. But one question that will come up is how hard will it be to keep doing trials of vaccines when there is an EUA for one or two vaccines? And I highlight this story because it nicely illustrates medical decision-making. For instance, many voices online have rightly voiced concerns over safety. Perhaps we should wait for more data, go slower. As a medical conservative, I disagree. There are times in medicine when waiting for better evidence is wise. But there are also times when waiting for perfect information is foolish. If a patient is crashing in front of you, you have to assess and decide often on imperfect information. So the pandemic is like a patient crashing. The sensible thing is to move forward, vaccinate the most vulnerable people, but crucially, and I think this is key, we ought to find some way to randomize as we go. This way we can continue to gain information on safety and efficacy. What do I mean randomize? Okay, consider that there will be a limited vaccine supply for months, and some people will want it and others maybe not. The economist Alex Tabarrok had a great idea, and I will link to his post on this. He wrote that there are many ways to conduct clinical trials while releasing a vaccine. He said we can make the clinical trials better by randomizing a phased release. He writes, suppose we decide healthcare workers or transit workers should be vaccinated first. No problem. You offer the workers the vaccine, you put the social security numbers of those who want the vaccine into a hat, like draft numbers, and then you vaccinate a randomly chosen subsample and monitor everyone. In any event, this vaccine news is highly optimistic. I hope it helps us get back to a sense of normalcy soon. I miss seeing you all at meetings. I miss the handshakes and the hugs. Okay, next topic. The rest of the podcast, I will go over AHA news, and when I return in 2 weeks, I'll have more reviews of more AHA studies. I saw 3 big stories from this virtual meeting. First is Samson trial. In 2015, The Lancet published a massive meta-analysis of trials of statin drugs. Did you know that 174,000 people have been enrolled in statin trials? The drugs have been found to show a 20 to 25% relative risk reduction in future cardiac events. This is super consistent. But the drugs can't help unless a person swallows it. Many people stop taking statin drugs. The question of side effects remains a quagmire. That is, until this year's AHA meeting. Here's the background. Like any drug, statins can cause rare and severe side effects like frank myositis or liver damage. We are not talking about these super rare events. When I talk about statin side effects from now on, I mean the common ones: myalgia, brain fog, fatigue. In blinded clinical trials that measure these side effects, there is no significant difference between statins and placebo. But in observational studies, in which patients know they are on statins, the reports of side effects are much higher. Now, the two ways to explain this discrepancy: one is that clinical trials have run-in periods and patients who complain about side effects don't get randomized. But the other way to explain it is the nocebo effect. The nocebo effect is when negative expectations produce a negative outcome. Nocebo effect is the opposite of the placebo effect. A good example of a nocebo effect is if I prescribe a drug and tell you it might cause difficulty getting an erection, then erectile dysfunction becomes much more likely to occur than if I didn't tell you that. Researchers at Imperial College London set out to study the possible nocebo effects in a super novel way. They used this N-of-1 trial design. In the Samson trial, they took 60 patients. Each of these 60 patients had previously stopped statins for side effects, and they gave these patients 12 blank pill bottles, one for each month, which they were to take in a random predefined order. 4 bottles contained a daily statin, atorvastatin, 4 contained a daily placebo, and 4 bottles were empty, hence the name N-of-1, 1-month trials. Of course, the patients and researchers were blinded. Patients recorded their sensations every day on an app. The primary endpoint was the nocebo proportion, and I know the first time I heard that, I struggled. Here's what nocebo proportion is. Think of a bar graph with 3 bars. Symptoms are on the y-axis. The months where there are no pills, the symptom scores are generally low, but not 0. The months they take placebo, there are more symptoms. In the months they take statins, if there is a true side effect from the biochemical effect of the drug, the symptom score, the bar, should be higher than the placebo bar. I have a picture of this in the column that I wrote. The picture really helps. Here's what the researchers found, and it is surprising. The mean symptom score for all patients was about 8 during the no-pill months, 15.4, nearly double that, during placebo months, and 16.3 during the statin months. So the difference in symptom score between the placebo and statin months versus the no-pill months was highly significant. But the difference in symptom scores between the placebo and statin months was not significant. The p-value was like 0.4. The nocebo proportion was 0.9 with very wide error bars. So that means that, yes, patients who take statins experience significant symptoms, but it is not from the statin. It is from the act of taking the statin tablet. At the end of the trial, the research team showed each patient their results, and 30 of the 60 patients resumed taking the statin. I think really this could be one of the coolest studies I've seen in years. Of course, the specific message from Samson is that if we teach patients about the nocebo effect, many would or could resume taking a beneficial drug. But the larger message, I think, transcends statins to all our therapeutic endeavors. Of course, drugs and procedures have biochemical and physiologic effects, but so does expectations. Our words and our actions can help or harm our therapies. For sure, we should show patients their angiograms after a PCI. Make the best of it. And for sure, we should be optimistic about the potential of a therapy to help. And I'm not advocating withholding important information from patients, but if we can be upbeat and empathic, our therapies may have a better chance of working. For instance, when I prescribe beta blockers to a reticent patient, I tell them that the drugs are illegal in golf because they are performance enhancing, which is true. So Steve Stiles covered the Samson trial. I wrote a column on it. I also just had the delightful pleasure of interviewing James Howard, the PI, and that's all up on the heart.org Medscape Cardiology. Second topic is a fish oil controversy. Right before the Samson trial presentation, the investigators of Strength RCT presented their trial's results. STRENGTH was a trial comparing an omega-3 carboxylic acid containing EPA and DHA 4 grams daily versus a corn oil placebo for the reduction of major adverse cardiac events. And JAMA published a trial. For the placebo in STRENGTH, corn oil was selected intentionally as olive oil may have been a beneficial placebo, and the investigators felt mineral oil could have been a harmful placebo. The STRENGTH trial enrolled statin-treated patients who were at high risk for cardiovascular disease, and the average triglycerides were about 239. The trial was stopped for futility earlier this year. There were absolutely no difference. The Kaplan-Meier curves totally overlapped. Key in this trial was that EPA levels were measured and found to be nearly tripled. Investigators also looked at patients with the highest EPA levels and still no signal of benefit. The STRENGTH authors did find, as did the superpositive IMPROVE-IT trial, that the fish pills increase the risk of having AFib, and I think this trend is underappreciated. Okay, now to the controversy part. Slide 11 and 12 of the STRENGTH presentation started the tussle. Here, the authors speculated on why STRENGTH was null and REDUCE-IT so positive. Recall that the REDUCE-IT trial studied pure EPA in the form of icosapent ethyl in a somewhat similar patient population, and REDUCE-IT found a massive 25% relative risk reduction in cardiac events, and this caught people by surprise because all previous trials of fish pills were null. The potential problem with REDUCE-IT was that the mineral oil placebo in that trial caused significant increases in LDL, CRP, and ApoB. The STRENGTH investigators offered possible reasons for the difference in outcomes. One is that the DHA is toxic. Another is that REDUCE-IT enrolled a slightly sicker patient population. The big one, though, is the unfavorable effects of mineral oil in the REDUCE-IT trial. In REDUCE-IT, the mineral oil increased LDL by 10%, ApoB by 8%, and CRP by 32%. In the Q&A, the PI of STRENGTH, A. Michael Linkoff from the Cleveland Clinic, questioned the results of REDUCE-IT. Boom. Then Deepak Bhatt, the PI of REDUCE-IT, countered, calling these comments absurd. Bhatt cited the fact that GELIS, another RCT of the pure EPA, found benefit. He also reiterated concerns that DHA could be toxic. My take here is that the mineral oil placebo in REDUCE-IT clearly associated with significant increases in atherogenic compounds. I concede that the pure EPA used in REDUCE-IT is a different product than the EPA-DHA combination, and so it's possible that EPA alone is beneficial. But the mineral oil effects creates lots of uncertainty. Practically speaking, and I understand that there won't be another massive and expensive trial, but if we wanted to be sure, you'd need a repeat trial with a more neutral placebo. Hey, and then on the matter of repeat trials, I'm just thinking, what would a sacubitril valsartan versus valsartan RCT for heart failure with reduced ejection fraction look like? Next topic, the HA featured 2 trials of AF ablation versus antiarrhythmic drugs in patients who had yet to try rhythm control. Both the U.S. STOP AF trial and Canadian Early AF trial were simultaneously published in the New England Journal. Medtronic, the makers of the cryoballoon ablation system used in these trials, was involved in funding both of them, though its role was much larger in the U.S. STOP AF trial. The background here is that the current practice holds that antiarrhythmic drugs should be used in most patients first, and AF ablation performed if the arrhythmia persists or drugs are intolerable. STOP AF and Early AF tested the cryoballoon pulmonary vein isolation system as the initial strategy. Now, STOP AF chose as its endpoint a composite of treatment success, a freedom from AFib, freedom from crossover to ablation, freedom from cardioversion, etc. Early AF simply used recurrence of any atrial tachyarrhythmia. Both trials enrolled relatively young patients about age 60 who had normal heart, small left atrium, and pretty low burden AF. The results were similar to the oodles of previous trials comparing ablations to drugs. Namely, STOP AF and Early AF found that ablation reduced the endpoint of AF recurrences. But there are many caveats. In STOP-AF, most treatment failures in the drug arm occurred while patients were taking ridiculously low doses of drugs. In 13% of treatment failures, the patients were taking no antiarrhythmic drugs. What's more, in STOP-AF, crossover from drugs to ablation was part of the primary endpoint. So in total, there were 51 primary efficacy endpoints in the drug arm. There were 99 patients randomized to drugs. But 15 patients, or nearly 40% of all primary endpoint events, met the endpoint not by having AF, but by being crossed over into the ablation arm. Now, most of these crossovers were for drug side effects, which is weird because the doses were so low. Only 2 of the 15 had documented arrhythmia recurrences. Now, I highlight this because you have to remember that these trials are done at ablation centers. The trialists are ablation proponents. They think ablation works. And no one is blinded, so there could be a hair trigger to cross people over. Hence, there's a potential for bias. The Canadian-led early AFib trial was much more rigorous. They had a protocol to escalate drug doses so as to give the drugs a fair chance. They used implantable loop recorders rather than intermittent Holters so as to capture all AF. And they measured quality of life pre and post using multiple questionnaires. And indeed, early AF found that the quality of life improved a lot in both groups, but significantly more so in the ablation arm. As for safety, STOP-AF obfuscated the results by listing many mundane events such as heart rate increases, fluid overload, influenza, rotator cuff syndrome, and this had a dilution effect. You had to go to the supplement to learn that 6% of patients in the ablation arm had procedural complications. Early AF was clearer about their complications, about 3% in the ablation arm and 4% with drugs. So here they rest in the New England Journal of Medicine. 2 trials will now be cited by proponents as saying early ablation should be considered to arrest the progression of AF and that AF ablation is safe and superior to medicines. This scares me. The first thing to say about translating this evidence to the bedside is that in many U.S. locations, ablation of atrial fibrillation is way overused. AF ablation is well compensated. The procedure makes lots of money for industry, for the hospital, and for us doctors. Doctors who make money for the hospital these days earn status as high producers. And if you're lousy at AF ablation and your patients require redo procedures, you actually earn more money, like it was in the old days of PTCA before stents. There is a huge moral hazard to lower the bar to who should have AF ablation. Another issue, which I wrote about in my column, was the lack of a proper control arms in any AF ablation trials. Dr. Rod Gimbel from Indiana made the point that patients in these 2 trials were young, healthy patients with early AF and low burden AF. Why is that important? Well, Gimbel cited 2 studies of such patients that show extremely low rates of progression over time. Some patients even regress. For instance, my atrial fibrillation regressed. Gimbel's point, therefore, is that we ought to have a conservative non-rhythm control arm. So imagine an arm in these trials with a reassuring AF team approach where a patient learns not to fear their arrhythmia and they learn how to reduce risk factors. And I would add to Gimbel's point that and say we also ought to have a placebo procedure arm, a sham arm. Why? Okay, consider the median AF burden in the early AF trial. The median AF burden was 0% in the ablation arm and 0.13% in the drug arm. Why then do patients in the ablation arm report feeling so much better? Both groups are at least 98% free of AFib. There has to be a huge placebo effect from this procedure. Finally, these are 1-year trials, and we also know that over time, AFib tends to recur. As I concluded in my column, I believe AF ablation has a role, but a slow, calm, medically conservative approach remains the right approach in lower risk patients. This procedure can cause significant harm. These trials should not be used to pressure patients into early ablation. On a final note, a reader sent me a very candid piece of feedback. This person wrote, over the past 1 to 2 years, the unbiased, level-headed views you used to provide have been replaced with a perpetual stream of anti-procedure and specifically anti-interventional cardiology propaganda. Your condescending and adversarial tone when talking about interventional cardiologists and the procedures we perform has gone too far. Sometimes it seems like your pseudo-fame has gone to your head and you've surrounded yourself with yes men and women that put you in an echo chamber. Okay, that's pretty candid. Over the 2-week break, I'm going to think about these comments. I really do think most doctors are trying to do the right thing. So that's it for this week in cardiology. As always, I am grateful that you listened. Thank you. And remember, friends, please, if you like this podcast, please take the time to give us a rating or writing us a sentence or two review. That helps others find us. Until 2 weeks, this is John Mandrola for the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.